Hello, everyone, and welcome to the United Nations University Institute for Water and Health Science and Climate Theories in this, our 30th anniversary year. My name is Jen Al-Sharaka, UNU-INWEH's Youth Fellow in Diplomacy and Sustainable Development, and I'm delighted to be your host for today's talk. For those of you joining us for the first time, our science talk showcases the diverse, policy relevant, interdisciplinary research of UNU-INWEH and our global network of IT groups. These sessions are designed not only to share cutting-edge science, but also to explore how the science to real-world solutions for water environment and health challenges around the globe. Today's session, like all of our talks, is being recorded. The video will be made available in an open access format following the event. And you can find recordings of all of our previous science talks on demand via our website and YouTube channel at unu.edu/inweh/science-talks. As always, we'll conclude with an interactive Q&A session. Please feel free to post your questions in the chat at any point during the presentation, and we will address as many as possible towards the end of today's session. Today's science talk is entitled Water Safety and Antimicrobial Resistance, Understanding the Indirect Role of Conflicts. It is my great pleasure to introduce today's speaker, Dr. Hygiene Abushamani. Dr. Abushamani is a water and public health expert specializing in water safety, antimicrobial resistance, and water sanitation and health, WASH, in conflict-affected settings. As UNU-INWEH's Water and Public Health and Conflict Zone Research Fellow at UNU, Dr. Abushamani focuses on the intersection of water, health, and the environment, emphasizing sustainable, rights-based, and evidence-driven interventions for communities impacted by conflict. Dr. Abushamani has extensive experience working with national and international organizations in Southern Palestine. Her expertise spans multidisciplinary research on water quality, public health, and gender responsive strategies in humanitarian context. She also led multi-stakeholder initiatives and programs aimed at strengthening WASH and public health resilience through capacity building activities, policy advice, and baseline studies. She holds a PhD in water technology and a Master of Public Health. Please join me in welcoming Dr. Abushamani for today's science talk. Over to you, Rima.
Hi, thank you, Jana, for the introduction, and thanks to the UNU-INWEH for giving me this opportunity. Good morning, good afternoon, good evening to those joining us in person and virtually from different time zones. It's an honor for me to present today about water safety and antimicrobial resistance to understand the indirect toll of conflicts. For those who might wonder what's the link between water antimicrobial resistance and conflict, today I hope that I will be presenting or illuminating this connection while walking you through a short journey to present the work under the GRISE project, a collaboration project between Geneva Water Hub and Imperial College, in addition to the Hygiene London Institute. I'll be walking you through this journey, starting with showing or presenting short context about Gaza and how conflict can affect the water safety in terms of antimicrobial resistance, spread, and dissemination. And after that, I will move to the science, presenting the main findings of the study conducted in Gaza that help to highlight some invisible risks that can inform humanitarian response within such a context. And then I will present a proposed framework on the indirect toll of the conflict, in relation to water safety and antimicrobial resistance, followed by implication on policy, and I will leave you finally with some takeaways to help you to memorize the main findings of our journey. I'll start by the foundation. And as all of us knows that access to safe water is a fundamental human need and therefore a basic human right. And thus this human right entitles everyone to sufficient, safe, acceptable, physically accessible, and affordable water to personal and domestic use. And as mentioned within the most recent Global Water Bankruptcy report, that water is the quiet infrastructure for everything the United Nations cares about. It's the quiet infrastructure for human security, for prosperity, for food and energy security, for biodiversity, environmental resilience, and public health, in addition to the climate stability and peace. And under the international humanitarian law, any attack on objects vital to civilian survival, such as water facilities, is considered as strictly prohibited. But sadly, in conflict settings, usually this right is violated and structurally dismantled. I'm moving from the principle to the sad reality, giving an example from Gaza, where it represents one of the extremist water and wastewater collapse in relation to conflict settings. And as you can see in this map, the red color represents the mass destruction, not only to homes and streets, it also represents the destruction for the water and wastewater infrastructure. And based on Oxfam report, people have very minimal access to when it comes to the quantity of water, to less than 5 liters per day per capita or per person, which is far minimum or lower than the values on the quantities recommended by World Health Organization and the sphere standards for emergency also. In addition to that, you can imagine that even prior to the 7th of October, Gaza, considered one of the highly densely populated areas with around 6,000 persons per square kilometer, which reached during the first weeks of the genocide up to 30,000 persons per square kilometer due to the forced displacement and in concentration shelters. And all of that has created an environment for waterborne diseases to prevail, including acute watery diarrhea, hepatitis A, which has been documented in UNRWA WHO reports during this genocide. And as usual, women, girls carry the heaviest burden of this risk when even the minimum requirement for dignity is not met. In Gaza, according to UN-Women reports, mothers, women, girls have difficulties in securing their dignity and hygiene needs. There is no toilet, no washing facility, and no privacy. And in this slide, you can see how sometimes water is used as a weapon during conflicts. And as you can see, on the top, the destroyed seawater desalination plant in the north area of Gaza, which has been attacked in parallel with the order to displace people from that area. You can see also how water pumps has been attacked also that save people in Gaza. This photo related to wastewater treatment plant, also in the north of Gaza, that this photo captured before the 7th of October. And nowadays, this wastewater treatment plant is non-functional, and it's even inaccessible, located in an accessible area. And this huge project was done to help with providing treated wastewater effluent with high quality to be recharged, to be used for recharging aquifer and to be reused for agriculture. And on top of that, the targeting of service providers and people fetching water, including children. But some of the incidents have been documented by UNICEF. As you can see in this figure, which was published during the COVID time to show how conflict affect the antimicrobial resistance with COVID, in conflict settings. This publication was led by Professor Mike Zaytoun, the director of Geneva Water Hub, and it shows how the attacks on water infrastructure, including that serve the public communities or that located within healthcare facilities, can affect the quality and the quantity of safe water, in addition to the attacks also on wastewater treatment plants that allow wastewater to reach surface water, or it can also infiltrate into aquifer and cause contamination that is difficult to be treated or handled. Within the healthcare facilities, the issue is more complicated, because within healthcare facilities, when the damage in water and wastewater infrastructure happen, then the water inside the healthcare facilities will be contaminated, and the waste will not, also the wastewater will not be treated. It will be mixed with domestic wastewater and reach community everywhere. In addition to that, within the walls of the healthy clinics, there will be an increased risk of nosocomial infections, including that caused by multi-drug resistant bacteria. And in parallel to that, in addition to the existing overwhelmed healthcare facilities and overwhelmed healthcare workers, with the breakdown in infection prevention and control measures caused by the increase even in received injuries within such context, there will be a sharp increase in the spread of antimicrobial resistant bacteria. and this will lead to preventable illness, and it might lead to even mortalities. And now I'm moving to the system from inside, because I've described the context from the outside, the vulnerabilities, the damages in the water system. So what would be the consequences from our study, in which we collected more than 130 water samples from desalination plant, from municipal water, from storage tanks, from wells. And then the samples were transported according to standard procedures to laboratory to be tested for the presence of bacteria, and to test their sensitivity to antimicrobial resistance. And then also we expanded our testing to include the antimicrobial resistant genes within the isolated samples. On the spot, free residual chlorine was tested for each sample, and the results of compliance with the standards were shocking, because the majority of samples were non-compliant to whether to residual chlorine or to the fecal and total coliforms. This table shows when we expanded our analysis to include further testing for other microbes than coliforms, which usually considered the main indicator for water safety in humanitarian context. We expanded our analysis to include Pseudomonas and Staph aureus, and we found a very shocking results, as around 2/3 of the samples were contaminated by one of the microbes, either coliform, Pseudomonas, or Staph aureus. And it's not only about the contamination of microbes, it's that these microbes were antimicrobial resistant bacteria. So when somebody infected by this microbe, it might be very difficult to find suitable or efficient and effective antimicrobial agent to treat such infection. For example, Pseudomonas species showed a resistance to one of the very strong and antibiotics called imipenem and piperacillin, and they are usually used as a last choice for treating resistant bacteria. Why I'm showing the results of Pseudomonas, why it matters, and this has been published on last year in one of the our publications, because this microbe considered one of the priorities for World Health Organization, and this microbe has the ability to form biofilms and to tolerate chlorine, the disinfectant used to disinfect water, and it's usually associated with nosocomial infections within the hospitals and clinics, and it has the ability to persist within the environment. And also, in addition to that, the antibiotic profile, resistant profile, we expanded the analysis to test for the genes, the resistant genes, and we've discovered that there is resistant genes within the isolates, whether coliform, Pseudomonas, Staph aureus. You might be wondering why we are interested about testing genes, because in aquatic solutions, bacteria can exchange their genetic material. So non-resistant bacteria can become resistant one when they acquire the resistant gene within this context. So one of the main highlights that we were trying to highlight within the findings, that we are expecting that within the current hostilities and existing mass destruction as casualties, AMR vulnerability will increase, and there will be an increased risk within healthcare facilities and outside the healthcare facilities. Building on that, on the findings, we can reveal some invisible risk that can inform humanitarian response. Why I'm telling that? Because when we tested for coliforms, the main indicator used usually during humanitarian responses to test for water safety, we started to realize that this is incomplete. It's important, it's simple, it's affordable testing for coliform alone, but it's not enough because other clinical relevant bacteria can be found within the samples that considered negative for coliforms. And based on the results, you can see that coliform were detected in around 12% of the samples, while Pseudomonas and Staph aureus were detected in around 54% of the sample, which means that if we only depend on coliform for judging water safety in such context, we will miss a hidden risk caused by other clinically significant bacteria. And this shows the limitation of conventional water quality monitoring within the humanitarian settings. And the findings reveal that Pseudomonas and Staph aureus are not predicted by coliform analysis. And Pseudomonas, as I said, that it has the ability to form biofilm and stick to the pipelines and the storage tanks, and it will keep causing a hidden risk within the water supplies, particularly in conflict settings. And so what should we do? The argument here is not to abandon the coliform testing because it's useful, but the argument is to place it within a broader risk-informed framework, tailored or contextualized to the context. If we have information, prior information or prior assessment within some areas under conflict that reveals that we have significant risks related to other than coliforms such as Pseudomonas or Staph aureus, we need to consider that during our humanitarian response. And all of that reveals that the antimicrobial resistance is not a medical problem, it's a system problem. And this brings us to the One Health dimension, where we acknowledge that microbial resistance moves across systems. And any effective intervention need to be multi-sectorial, because AMR and microbial resistant can move with water, with contaminated water and wastewater. They can reach human being communities, and it can cause serious infections if not handled in or managed in a proper way. Another dimension that I will not expand on it, it's the effect on animal health, because usually antimicrobials and antibiotics used to treat animals, particularly poultry. And the waste coming out from those farms can carry significant risks when it comes to microbial resistance. And when this waste, usually in conflict setting and in developing country, it's usually mixed with the domestic wastewater, adding additional risk. So any intervention need to consider that microbial resistance not only a medical or clinical issue. It's not only the risk within clinical walls. It will move across the sectors if not managed properly. So why the conflict setting considered as a magnifier to AMR risk? Because usually in conflict settings, antibiotics are unregulated and misused, and the water and sanitation infrastructure usually destroyed or non-functional particularly during armed conflicts. The healthcare or the healthcare capacities, it's overwhelmed, and the infection prevention control measures usually break down. The surveillance is affected, and it's minimal or absent, and there is a widespread of sewage outflow causing environmental exposure. And back to the first diagram or figure that I presented, to show that water system within the conflict setting can become a reservoir and transmission pathway for resistant pathogens. It can move from the healthcare facilities in and out with people who enter and exit the healthcare facilities. It will end up with affecting communities. In addition to that, the wastewater coming out from the healthcare facilities, if not treated well, and if the wastewater treatment plant is targeted by direct attacks, it will cause the spread of the microorganisms, and it will reach the surface area, the surface water, causing its contamination. Even it will infiltrate into the aquifer. So the indirect toll is the silent toll. The diseases and illnesses that never appear in casualty counts, because during the wars, the armed conflict, we count this as the direct, the visible ones that caused by blast injuries, by the air flight, because it's immediate, we can visualize the physical impact directly. But what about a patient who died three weeks after a surgery because of complications related to infection with microbial resistance because the water and the environment within the healthcare facilities were contaminated, and which compromise the infection prevention control within the facility. What about the sepsis developed for unit during delivery in a delivery room that lack sanitation? So based on this proposed framework, the word the armed conflict will cause direct war deaths, direct war injuries. In parallel to that, it will cause destruction to the water and wastewater infrastructure, which indirectly will affect or compromise the infection prevention control within healthcare facilities, and it will affect the provided services, including wound cares, leading to indirect infections and preventable illness caused by sepsis, by severe diarrhea, and then indirect deaths. And that's why we call it indirect or hidden, because it's usually not presented within the formal reports of the casualties or deaths during the wars. So back again, the armed conflicts will lead to the water and sanitation collapse, whether infrastructure or governance, and then this will affect the infection prevention control and will lead to a transmission of contamination, mainly caused by microbial resistance, and this will lead to preventable infection that can lead to indirect mortalities. So what can be done? So the first thing that in conflict setting, the infrastructure related to water and sanitation need to be protected according to international humanitarian law. And if it has been targeted, then the restoration of service will need to be ensured as immediate as possible. Because the water infrastructure is not only about service system, it's the front line of public health protection. So the main priority action that need to be considered within conflict settings is to, as I said before, to protect the water infrastructure, to try to have innovative emergency compatible treatment system. And from Gaza experience, it need to be decentralized and mobile or portable as possible because of the forced displacement experienced in such complex context. We need to consider the infrastructure of water safety within healthcare facilities, and we need to consider also wastewater management within this context. The second pillar that we need to consider is to have an integrated AR and water surveillance system within the broader concept of One Health. Because as we mentioned, that usually the routine coliform testing misses microbial resistant. It also, during conflicts, we have weak laboratory capacities. We have fragmented services. We have also under-reporting issue when it comes to the indirect tolls of water and sanitation collapse within this context. And so the surveillance system need to consider the water supplies, whether drinking or domestic. It need to consider the wastewater, need to consider the vulnerable settings such as healthcare facilities, and it also need to cover environmental reservoirs. And the third pillar is the stewardship and governance, not only for the water and sanitation part, because we need to consider the stewardship when it comes to the antimicrobial usage. The antimicrobial stewardship in healthcare need to be considered and regulated as possible. The humanitarian context need to, or intervention need to consider that through their interventions. They need also to integrate community-based awareness and partnership with local actors as possible if there is a weakened governance system. The pharmaceutical disposal need to be also regulated as possible to have safe disposal, because when it reached this pharmaceutical disposal, when it reached the wastewater, it will induce another pressure for having further risk when it comes to microbial resistance. So we need to consider rethinking the water safety in conflict, because water systems in conflicts are not passive victims of war. They become dynamic ecological systems that shape infection transmission, antimicrobial resistance, and the indirect mortalities. And therefore, protecting water infrastructure simultaneously is an engineering priority and a public health intervention, and should be considered with the humanitarian obligations. So I'll leave you with those takeaways. I'm repeating maybe this is because it's very important to consider that the water and sanitation is not only an infrastructure, it's an important infection prevention and control measure. And any collapse within this system, the water and sanitation, will be considered as a risk multiplier that contribute to the indirect morbidities and mortalities in conflict settings. And when we consider water safety, we need to frame it within a broader risk-informed framework, customized or contextualized based on the context. So we need to depend on previous assessments if it's available, or if we can have real-time assessments. This will be very useful during emergencies. The water service providers and water infrastructure need to be protected, in addition also to the other health infrastructure and health providers, because it all contribute to the holistic system of protecting people's health and prosperity. And water safety is is a core clinical risk control and requires coordinated cross-sectoral governance. And as I said, within the holistic One Health approach, we need to consider that AMR is not only something medical, we need to consider the three dimension, the environmental dimension covering the water and wastewater, and the human dimension related to the role of people and community in transmitting the infection, and the animal health in terms of the usage and the waste coming out from the farms that can add more risk when it's usually mixed with the wastewater. Thank you. I leave the floor to you if you have any question. I'll stop sharing.
Thank you, Dr. Umar, for a really insightful presentation. We will now move on to the Q&A portion of the science talk. One question that I had is you use a very important case study of but that case study is still going on and it's ever changing. Is there any is there any drawbacks or benefits that come with using such a ever-changing and present case study?
Jenna, if you mind, because the voice is not clear and it's very fast, and there's an echo with the voice. Would you mind repeating the question?
Of course. You use a very important case study, which is SENSA, but that case study is it's ever changing and it's like a very new case, relatively new case study. Is there any drawbacks or maybe benefits from using such a new case study?
If I hear the question well, you are speaking about the application of this case study in Gaza in other contexts. Am I right? Because
not particularly, but just that this case study new things come from this case study every day, and so I imagine that something that was true yesterday may not be true today. Is that something that challenges your research?
When it comes to challenges, because back again, Jana, because the voice is very, very, very. Could you write the question in the chat box?
I can try to write it, but I feel like that might not be.
Speak slower.
Okay.
Yeah, slowly.
Okay. So the case study of Gaza is it changes every day, doesn't it?
Yeah.
So when you're using it as a case study for research, there has to be some difficulties that come with the fact that this case study is changing a lot. Is there?
If you mean that the results or the finding will be changing according to the situation, if it's repeated in other contexts, it can. We can have different findings. That's why one of the recommendation is to have a kind of real-time assessment as possible for the water safety, particularly within the vulnerable contexts and communities. The issue that even those findings, even prior to the 7th of October, Gaza was one of the contexts that suffered from protracted and long-term conflict. The results here show that there is an expectation that the risk will be multiplied and the risk will be more every day under the conflict, under the armed conflict.
Yeah, Thank you. Any questions from the audience?
Trying to remind you online when it gets them.
So,
For those of you online, please, if you have any questions, you don't hesitate to add them to the Q&A section, and we'll happily read them out for Dr. Abushimar. Are there any questions in the room? Yeah, great.
Great, thank you. I'm just curious. I don't mean to start anything controversial. The recommendations, especially the policy aspect, I want to ask, who are they for? Who are supposed to be the policy actors that you are targeting, for this recommendation?
thank you, Dr. Grace. Let me repeat your question to be sure that I've heard it well. You are speaking or asking about the target or the audience for the policy actions. Am I right? Okay.
Yes.
So this is, thank you for asking this question, because it's really something tricky, because during conflict settings, the governance situation is varies. So you will find within some special context that the government or the public entity is still strong, and they have the power to enforce and to control the humanitarian interventions. In other contexts, the public sector or the government is weak, and the lead usually for humanitarian and emergency response undertaken by humanitarian NGOs and humanitarian sector. So the policy within the policy document, or we have introduced an introductory that help to guide and to categorize whether under conflict setting have a weak governance system, or still can handle the reconstruction, the surveillance of conducting surveillance, and in addition to that, the stewardship when it comes to water and wastewater. So it varies according the context, and that's why within emergency settings, any intervention need to be risk informed and contextualized according to the context. I hope that I answered your question.
Oh, really? I'll let it be for now. We can continue the debate offline.
Thank you. We have a question from Dr.
Okay, Rick, thank you so much for the insightful presentation. I know these are findings that will not get news headlines. And mostly they talk about the impact on women and children. Now, reflecting on your findings, how are men affected in these situations?
How are men affected? Okay, thank you for this question, Dr. Graham. Actually, the effect is expected to reach everyone. With what we are presenting, it was that we think that it carried women and girls carries the heaviest burden, because they have additional physiological, in addition to the their rules in health, in taking care and domestic rules. They have physiological needs when it comes to maternal health, when it comes to menstrual health. So for the men, they will be affected for sure, and based on the context in Gaza, starting from being direct targets during the genocide. I'll give you an example. For example, being a service provider and a man who's responsible of delivering safe water to people in this context. We have witnessed direct mortalities attributed to that. This is the direct morbidities. So the indirect ones, if one of those have been injured and he will be transferred to the healthcare facilities, and there he can get infection, which could be caused by resistant bacteria, as I said. And this will cause inflammation or amputation. And this is considered indirect because it wasn't related to the direct threat. It was a consequence related to the deteriorated situation during the armed conflict. This is two examples, for example, how men can be affected during or based on our findings. I hope that this answered your question here, Ibrahim.
Yes, Reem, that was wonderful. But I have a follow-up question on your framework. I think most times we focus on the current events that are evolving from war settings, but we realize that in other areas like Iraq, when we're working on a peace, we realize that over time, then the impact testing or the long-term impact testing. Now, drawing from your current findings, how will you project, what do you think happens even if the war in Gaza stops today? Because your framework didn't highlight the time element.
If I understand your question, it's about the long-term impacts related to our how it's reflected within the framework.
Yes, please.
Okay. So the framework was developed based on consultation with key informants from multidisciplinary backgrounds related to water, public health, environment. And for the long term, today, for example, in Gaza, today is the 1,000th day after the genocide. So that it's not after, it's during genocide, and it's still ongoing. So this framework reflects not only the after 7th of October conflicts or incidents or a genocide. It's because Gaza is under the protracted long-term conflicts since decades. So the findings not related to a direct, or how can I say it? It's not an immediate impact, because even the contamination for the aquifer, and it will not happen within days or months, and we found contamination within the aquifer. So it's related to the long-term impacts of the armed conflict. And this was reflected, the framework was mainly to reflect the indirect things that we might miss when counting the direct physical casualties happen because of the armed conflicts. The main idea is to start thinking about the indirect, the missing part, which is huge. If we need to be precise and accurate, we need to consider all those consequences that happen, that might be witnessed after long time or short time of the incident.
Thank you.
We have a
No
question
problem.
here. Thank you so much for another fantastic presentation. I think your research is particularly impactful because you combine humanitarian and social causes with technical research. I'm wondering if you could talk a little bit about this collaboration that you had and how you started to work with Imperial College and GI Rise. What the sort of personal story behind this is?
So actually, this was a part of the Geneva Water Hub contributions. Not for me, it wasn't direct collaboration with the Imperial College. It was under Geneva Water Hub contribution within G Rice project to assess the indirect toll of the war. So part of the project were completely health related. And it helped, for example, but I think they still in the publication issue, how to estimate the unseen burden or risk from lack of vaccination among children, for example. This will cause with time another burden when the children are more susceptible to acquire infections. So our part from the Geneva Water Hub was mainly to integrate the water-related risks, and based on the study with a specification on the microbial resistance, because in Gaza it was the first of its kind to address microbial resistance in water supplies in healthcare facilities. Not only it's not about microbial resistance within healthcare facilities. It's about the detection or assessment within water supplies. So it was a kind of collaborative work, but or our side, it was about focusing on water-related issues,
Thank you so
not
much.
not pure medical issues. No problem. Thank you.
Thank you. We have one more question from Ray.
Okay, I'm just curious about, because each time recently we had to advocate for an integrated framework, between water and health. And as scientists, as professionals, I found that very, okay, I won't tag it, but it's a bit of I need somebody to borrow me a good word here, that we have to be flagging that water is actually at the upstream of public health. Where did that mismatch come from? In your opinion, in your experience, and in the work that you've done, where do you think that mismatch comes from? That it's not so clear to public health scientists that water actually sits at the upstream of that.
Thank you, Grace. If I hear your question well, it's about how this presentation or this talk reflect the impact on public health, you mean?
Impact on public health, but one of your recommendations is integrated, that there has to be an integrated framework, between water safety and public health.
Yeah.
They need to come together across sector. And I'm wondering, as scientists, where did that mismatch come from? That public health scientists don't appreciate the fact that water sits at the upstream of public health.
for the framework on water safety, you address a very critical issue because this part of this talk was mainly about highlighting the indirect toll of the conflict. But for the water safety and the integration of water safety surveillance within the health surveillance, this was one of the main recommendations to include, because usually at healthcare facilities, for example, they have a very efficient infection prevention control when it comes to disinfectant of equipment, medical equipment, surface areas, for, any tools for the surgical operations. But when it comes to water, they assume that if there is, for example, if it's disinfected with chlorine, it will be safe. This is a misconception that based on this study, we managed, but I didn't have the chance to present it today, to advocate for integration of the water safety within the infection prevention control within healthcare facilities. So water safety, you are right, addressing the water safety within the health care facilities is a very critical issue, and the water safety is a critical pillar to ensure that the stewardship of even infection control and prevention within any place, within the healthcare facilities, within the displaced shelter and during emergency. So there is another framework for the water safety. I hadn't the chance to present it today, as I said, because the main issue was to highlight the indirect toll of conflict.
Thank you.
Thank you.
Thank you, Dr. Kumar. We have one question online that I'll send to you so you can give them a response. And thank you for a very thought-provoking and inspiring talk. And thank you to everyone for the engaging discussion. This brings us to the end of today's UNU-INWEH Science Talk. If you enjoyed the session, remember that all of our previous talks are available on our website and YouTube channel at unu.edu/INWEH/science-talks. Feel free to revisit and share them with your colleagues. We'll be back next week for another exciting presentation exploring new ideas at the intersection of water, environment, and health. Thank you for joining us today, and we look forward to seeing you at our next Science Talk. Have a wonderful day.